Dr. Dilip Kumar to please come onto the stage. We now turn to one of the most transformative developments in chest pain evaluation of the past decade, high sensitivity troponin. Our next speaker, Dr. Dilip Kumar, is from Manipal Hospital in Kolkata. Dr. Kumar will walk us through the evidence-based algorithms, the 0 hours to 1 hours to 2 hours pathways that are changing how rapidly and safely we can rule in or rule out ACS in the emergency setting. Now we pass the stage to you, Dr. Dilip.
Very interesting discussions. Lot of good discussions happened. Lot of clarity needs to be there in future going forward. Lot of modalities. There is a prevent trial we just discussed. There are some trials, randomized control trials, which give us insights, which say that it's randomized control trial, but still you get some recommendations also, but the practice remains there, like thrombus aspiration. It's in guideline, class 3 indication for not to be done in MI cases, but still we do thrombus aspiration. So we have to read between the lines and we have to devise our own idea how to go ahead with that. And for decades, the diagnosis of non-STEMI, especially non-STEMI, was a waiting game, looking for, slowly watching for the enzymes to go up, the ECGs to change, and then we were diagnosing non-STEMI and working on that. But with this advent of high sensitivity troponins and biomarkers, now we are getting a trade-off between the luxury of time and the need of the precision. We need to precisely define the problem and to act on that. So to begin with, what's a biomarker? Biomarker is a substance used as an indicator of a biological state. This can be objectively measured, and the objective state could be physiological, pathological, or could be a pharmacological response to a therapeutic intervention. So may get an idea about which was the first biomarker used to diagnose acute myocardial infarction. So I think everyone would clearly put their fingers on as AST, and rightly so. The first biomarker for acute myocardial infarction was an AST, and it was proposed in 1950s. Then we got LDH, and then CK, CKMB, then troponins, then high sensitive troponins, and now finally we are standing at point of care troponin analysis. So point of care troponin analysis where we can get the results in 15 minutes, and that creates a lot of difference. So what's the troponin? Troponin is a complex, it's a 3 protein, complex of 3 proteins, and these are basically calcium sensors. So troponin C, troponin I, and troponin T. And why we measure troponin I and T? Because they have got some amino acid sequence which is specific for cardiac isoforms, and that's why it's more precise and more kind of specific for myocardial injury. And this is the difference between contemporary versus high sensitivity troponins. High sensitivity troponins, they ensure and allows us to measure normal troponin level in the body. So earlier the levels which now we can detect were undetectable. And you can appreciate here in this slide, the young individuals, the troponin we can measure at this moment, and once there is a myocardial injury, the troponin is elevated, they can be measured anyway. So what is the release pattern of troponins? So damage to the heart muscle causes a biphasic response and release of troponin. First, the troponin which is there free in the cytoplasm gets released, and they contribute to 4 to 5% of troponins which are there in the cardiac myocyte. And then came the usual burst, slower, more prolonged release of troponin from the muscle, the cardiac muscle after the injury. So this slide shows how in 1995 we were able to identify and detect troponins at the level of 10 nanogram per liter, and these were a little towards the 99th or 100th percentile in a normal population. But nowadays with high sensitivity troponins, we can measure up to 2.5 nanogram per liter. So we can detect very, very low amount of troponins and at a duration of 2 to 3 hours after myocardial infarction or non-STEMI. So this creates a difference, and that's why the troponin algorithms now enabling us to detect these patients earlier. So you can see here the level of detection. The level of detection earlier was 99th percentile with coefficient of variation 10%. This with the normal assays, with the high sensitivity cardiac troponins, the level of detection comes to around 10th to 20th percentile with coefficient of variation of 10% exactly same. So it's highly sensitive, and we can measure it within 2 to 3 hours of the chest pain. There is some difference between the cutoff between male and females, and males have got a higher cutoff for normal cardiac troponin range. And the cutoff varies from the different manufacturers. Also the cutoff varies between the different central laboratories. So they can standardize their troponin labels, they can give you a cutoff. So if you make an idea, it has to be around something like 35 to 50 highest cutoff for males, and females around 20-25. So this is an average, but there can be some variation. Now coming to the basic question, the chest pain pie in the emergency room, emergency department, how emergency clinician handling the show, patients coming with chest pain, whom to send the patient back home with 100% kind of assurance that you are not going to develop any myocardial infarction. And we have to just pick those patients who have potential or who are exactly having non-STEMI or STEMI, and then work on that. So this is a big dilemma, and also this is a statistics which can give us little insight. How many of ER chest pain patients will have a STEMI? Yes, this is less than 1% or maximum to 1%. So only 1% of patients coming with chest pain, they have STEMI, and and if we extend it to 2-3%, it becomes non-STEMI. Majority of the patients have got atypical chest pain or non-cardiac pain. When an emergency physician gets this ECG, there is no doubt he is going to work on that. There is ST elevation myocardial infarction. Straightway the STEMI protocol gets activated. The interventional cardiology comes into the picture. We ask the patient to be taken. There can be a point of care troponin, but I think this is just a formality to just define that yes, it's acute myocardial infarction, and quick echo, and then patient in cath lab. Obviously, the door to balloon time needs to be adhered to. 98% of the cases, the ECG looks like this. There is a significant changes, or ECG looks almost normal. Patient complaining of chest pain, what to do, and then the clinical team of emergency department starts working on that. Patient's physical examination, chest X-ray, echo, and history. But history can be misleading. History, what if the patient can't communicate? They give you vague ideas. The patient is intoxicated. Patient unable to, patient is 90 years, dementic patients. He's not going to tell what is the nature of the pain, mental illness. Then you need to fall back on something which is more objective. And the basic idea here, who should be admitted and who should be sent home safely, saying that you are not going to have heart attack or ischemic non-STEMI. So all the algorithm which comes into the picture with troponins applies here, and this is recommended in AHA, ESC guidelines, 0 to 1 hour. You have to get a sample once the patient comes to the hospital, emergency department. Also within 60 minutes, another sample has to be sent, or maybe 2 hours you can send. But the idea is you have to get the result within 60 minutes of the, when the blood is taken out. And there is a difference. You send it to central lab. Ideally, it should come in 60 minutes. It comes in 1.5 hours, 2 hours, 3 hours, and next 1 hour sample will come 3 hours, 4 hours late, and then you lose time. And although the definitions are set, guidelines are there, we need to see how it is practically feasible, and we have system with point of care devices that it can be possibly done. So there is, these are already established in guidelines, and the essence is, this is the fourth universal definition of myocardial infarction, and it all hovers around the troponin, rise and fall. So rise and fall of troponin with one value of the 99th percentile plus one of the following. So you need to document that before we go ahead with an intervention. So, and the universal definition of myocardial infarction clearly states the role of troponins and these algorithms. And just to complete it, what are the types of myocardial infarction? From the universal definition, type 1 is normal, what we saw the cases, a little while back, these plaque rupture, plaque erosion, thrombotic lesions, and you're getting STEMI, non-STEMI. Type 2 is demand and supply mismatch. Patient is sepsis, patient is tachycardia, getting a troponin raise. This is type 2 MI. Type 3 is sudden cardiac death, possibly because of the, thrombus or plaque rupture erosion, but we are coming to know after the patient has died through post-mortem or, another ways. And type 4 and 5 is post-PCI and post-CABG, myocardial infarctions. So here is the 0, 1 hour or 2 hour rule to rule in and rule out, STEMI and non-STEMI. If you take the sample, once the patient is presented in emergency department and it shows very low, or you repeat it after 1 hour, delta is also very low. This is, we can rule out, clearly. Of course, we have to take into account other factors which I am going to discuss. If the patient has a high baseline troponin and the delta is also high, then they are ruled in. Patients are admitted, and the further steps are taken. And in between, we observe these patients. Besides troponins, we also go for risk scoring of the patients, like we take the history, whether the patient pain is typical or not, whether the patient pain is atypical, ECG changes, which Queen of Heart can give us an idea, but ECG changes we also can see. I think any emergency physician can see whether it is suspicious, looking clinical ischemic or not. Age of the patient defines the risk factors, and then troponins. So with the heart score, we get an idea whether this patient should be ruled in and ruled out. And here the evidence. Anything comes with evidence. You can see here in this initial landmark study, a ACS study, the ability to rule out was 100%. From there, everything started working. Once you see that 0 hour, it is less than 1.2 nanogram per liter, and 1 hour it is less than 3 nanogram per liter, then you can safely rule out based on heart score. And the specificity of this ruling out is almost 100%. In the first study APACI. And also to rule in, if you apply this algorithm and you rule in non-STEMI and STEMI myocardial infarction, the positive predictive value is 84%, and since specificity is 97%, it's very high. Especially ruling out is 100%. And this was followed by other studies which were again randomized controlled trials, and they again showed similar kind of benefit. Almost 99.9% to 100% of rule out ability. And that's why these are in guidelines. We can use this algorithms to safely rule out patients who can go home, and rule in patients who can be further taken in, further risk stratified, and if needed, go for an angiography and angioplasty. There is a cherry on cake. If we measure these troponins, we also get to know about the future adverse risk, the ability to predict the future outcome, cardiovascular outcome of these patients. So patients with high baseline troponins have a adverse 1-year mortality. And with this advent of point of care test, it's become more practical. We can use this with standard central lab testing. You may miss the time, you miss the important crucial time when we can intervene. With point of care tests, we can deliver the test results within 15 minutes, and critical decision making can be done, and finally we can work on that. And it's not easy, it's not very difficult to get a blood sample, quickly do troponin in the emergency, and there this is in the guidelines in recent EAC and AHA guidelines, 0 to 1 hour, or you can use 0 to 2 hours. Once you are pretty sure you are ruling in the patient, You're not ruling out, ruling in the patients. You can further risk stratify by Grace, TME score, and depending on that, you can take the patient for intervention for an angiogram, or you can go for a conservative management. So let's look at some of the situations, some of the clinical scenarios. So suppose this is an 82-year-old male, hypertensive, diabetic patients coming to the ED with acute onset chest pain, retrosternal chest pain, radiating to left arm. It's a very typical chest pain. And the patient's vital signs are normal. Clinical examination is also not contributory. But the troponin at baseline is 35. What are you going to do with this patient? Definitely we are going to stick with the patient. If there is no ST elevation, there is patient ECG is not contributory, still we keep this patient. After 1 hour we do this test, it comes to be even more, and then you can see here we can risk stratify these patients according to the TME score system, and then you take the patients after 1 hour or 2 hour, troponin becomes 60. Clearly you take these patients for an angiogram and you find that there is a disease in the LAD and you fix that. So this is how a simple 0, 1 hour, 2 hour test can give you an idea. In addition, if we utilize the other risk factors. There are some common doubts which I am going to clear it. 0 and 1 hour troponin should be performed in the ER itself, or one test we are doing in ER, one we are sending to central lab. Which way we should go? So ideally both the tests, if we are looking at delta, should be done in the same device. It should, if it is central lab, it should be central lab. If it is in the point of care test in the emergency department, it has to be POC in emergency department. 2 tests, 0 hour, 1 hour, 2 hour. You see the delta, you see the baseline, you see the jump, and finally the rise of the troponins. So same instrument should be used. The point of care and lab results can vary a little bit because of their standardization, and should be stick with one laboratory. In case you think the point of care is wrong, then keep this patient, do other tests, and then reconfirm it, go to send the samples to central lab. When you are clinically feeling that this is ischemic and the point of care test showing less than 1.5, keep this patient. Observe, we can send the patient, the lab, again to central lab. This can be case 2, 52-year-old women present with vague heaviness over the left side of the chest, no radiation, but patient doesn't recall the duration of chest pain. She says 5 hours, 6 hours, and she is known hypertensive, hyperlipidemic, but she has a pain of 5 hours duration. And the troponin here is, we can do the troponin here and it comes to be less than 2.5. Should we repeat the troponin test or not? So here we can apply at 5 hours of chest pain. It was atypical, you are doing point of care test, it is less than 2.5, there is no point repeating it. It's already 5 hours. You can safely counsel the patient and you can send the patient home. There can be case 3, a situation where the patient is 45-year-old man with history of recent travel, no comorbidities, comes to ET with non-specific chest pain, heart rate of 80, BP of maintained hemodynamics, ECG is within normal limits, troponin I was 30, but the patient is giving non-specific chest pain sort of history. What do we do? Echo is normal. Repeat HS troponin done after 2 hours was 60. Repeat ECG was normal. He was asymptomatic, wanted to go home. Should we send this patient home? Absolutely no. Because there is a delta, there is a troponin baseline has raised, and this patient is going to have MI, is probably having MI, and should be risk assessed TME score or Grace score. Depending on that, treatment should be offered to the patient. And finally, this again a 35-year-old male, no comorbidities, comes with history of epigastric pain, heart rate of 100, BP of 120/70, ECG, echo, X-ray normal, troponin of 3.7. So 3.7 is a borderline. And repeat ECG 2 hours normal, repeat ECG, repeat troponin 2.7, again comes to be same range. Still complaining of epigastric pain. Are we going to leave this patient? Absolutely no. We are going to keep this, observe this patient. It falls between 2, rule in and rule out. We may need to elucidate non-cardiac cause of chest pain, epigastric pain, or maybe the patient may turn out to be cardiac, you never know. So this is intermediate group of patients, we need to observe these patients. So ruling in and ruling out ACS in ED is important, and it has to be quick. It has, as per the guidelines, it should not be delayed rule in, rule out, because there is a trade-off. In delayed rule in, you increase the morbidity and mortality. Delayed rule out, you increase the ED burden. Finally, to conclude, we have to look at we should know the other reasons why troponin can be elevated again. So there can be tachyarrhythmias. A heart rate of 120, 130 can give you high troponins. Heart failure can give you high troponin. Hypertensive emergencies, critical illness, myocarditis, tracheosupercarditis. So the list is long. We need to know this list. CKD patients. So patients with heart failure, tachyarrhythmia, CKD. If the upper limit is 50, up to 2 to 3 times we can still consider this borderline. If it goes more than 150, 200 in CKD patients or high heart rate with a borderline ECG, you can still feel that this can be non-ischemic. So we need to know these non-cardiac problems which can lead to high troponins. So clinic is essential, comorbidities needs to be known. Assay the variability, we need to know the variability from manufacturers to manufacturers, your cutoff, your lab cutoff. But overall it is around 50 in male and 25 in female. There are 6 specific cutoffs, and if we utilize POC, we can further robust our clinical diagnosis in emergency department for chest pain evaluation. Thank you so much for the patient hearing.
Thank you, sir. High sensitivity troponin has truly redefined our diagnostic timelines, and you've outlined the evidence with great clarity. We appreciate your contribution. Can we have any questions, please?
Yeah, Shishi.
Highlighting high distance troponin I. Now, I wanted to point out a few things which I come across in clinical practice. The ECG showing a 10 millimeter ST elevation. Troponin I is sent. Is it waste of resources? How often it is done? Can we have a raise of hands? Can we have a raise of hands? In my hospital, sometimes it is sent inadvertently.
Yeah.
Probably it's a routine protocol, what you can call it, and then it's just wasting resources. And then say it's 25,000. It's a 10 millimeter ST elevation. You don't need a troponin I in that situation. Second important point, before you can send a troponin, but probably for us in India, especially in tertiary care where you have an echo machine, you can do a very quick echo and look at wall motion abnormalities and pick up an MI before your troponin results come back in 15 minutes. You can make a diagnosis in 5 minutes if you have an echo machine by your bedside, and ECG is non-diagnostic. You can send a troponin, immediately do an echo. You don't have to wait for the troponin result. If there's an RWM in LAD territory or inferior wall, this patient is, you need to alert the cath lab immediately. A third important point is sending troponin I from acute medical care and renal units, dialysis units. Somebody has a chest pain or has no chest pain, he's on ventilator, he's sepsis, everything is going on him. And a troponin I is sent, and then, hell breaks loose. The family is immediately after they want to catch your throat actually, because troponin I is elevated and you're not doing anything. The guy is extremely sick, low platelets, sepsis, advanced renal disease or heart or lung disease, liver disease. Nothing much to be done there, I know, but we are sometimes in real deep trouble when this comes positive and you're not doing anything for this patient.
Absolutely. I think very, very important, pertinent, practical points. The ST elevation, the pathway is very clear. The emergency department doctors can identify, send it, and STEMI pathway is getting activated. Sending troponin or doing a POC is maybe a waste of time, waste of energy, and waste of resources, but these are in guidelines. If you diagnose this as a kind of universal definition of MI, it hovers around that, but practically it is not done. In our center, it is also not done. And the second point, which is very relevant, I often ask my fellow not to send troponin patients who referred from critical care department with a sepsis and all, with a kind of patients in not about able to be weaned off what's happening. Then I send them do an ECG, do an echo, please don't send troponin I. If it becomes 300, 200, then there will be a lot of problem. Families will be after you. Physicians will be after you, critical care doctors will be after you, trying to shrug off the responsibility, but that is fine. We have to explain the patient that is a type 2 myocardial infarction, if at all it is happening. It can happen because of the demand-supply mismatch, tachyarrhythmias and all is happening. And obviously if it goes in thousands to multiple thousands, we need to again chip in and look at what's happening, if the cardiac factor is contributing or not. And very rightly pointed out, these POCs are not being utilized, especially in STEMI, but in non-STEMI it does have a value. It does have a value.
Yeah, as Dr. Srikanth has pointed out, common misinterpreted and misused investigation as we see. Everybody advises troponin even in the peripheries and for non-cardiac pain, all these things. Apart from that, probably one recent indication which we are doing also is the perioperative increase in the troponins, and which is supposed to give a poor prognostic indicator, and you have to necessarily do in high-risk patients, especially because patients can't comply, and then this next 48 hours you have to do a serial troponins in suspected patients, and that gives a poor prognosis.
And there is also a role of pro-BNP and troponin in giving clearance to non-cardiac patients. And the baseline troponin can give you a hint that patient's prognosis can be wrong, and you can further intensify your cardiac workup or evaluation before we give final clearance to these patients. Yeah.
Absolutely.
Especially because when you look at the risk scores, intermediate probability, I think we can further refine the risk by doing this biomarker approach.
Absolutely.
Also in ischemic stroke patients.
Yeah, it's
right. Having ECG changes, and then the troponins will be elevated. It's very difficult to. How do you diagnose an acute MI?
Yeah, in subacute hemorrhage, ischemic CVA, even ICH, the troponins are high, ECG changes are there, and then you are really confused. But as long as it's not STEMI, you get ST changes downwards. And depending on the pathophysiology in ischemia, there is no point harm giving aspirin, antiplatelet statin. Yeah, that's how we go ahead. Yeah.
I think one important thing, not just getting the number of the high sensitive troponin, the problem for the clinician is interpretation of the high sensitive troponin, because it is a cognitive burden on the person. So it is not like a positive negative. It is not a black and white. Life is full of grays. Not EYS, GREYS.
And there is also a variation. There are some laboratories which give you nanogram per liter and then give nanogram per deciliter, and then entire thing is messed up. And you should know it is 2000, 100, and then you are really confused what's there. So we need to check that which value they are giving. Nanogram per liter should be the standard. Yeah.
Sir, there are, in my view, we have to take troponin T as well as the rest all the parameters into consideration. Yesterday I saw one case. She presented with a WBC count of around 25,000. She has chest pain and she did not have any typical changes as to acute ischemia, infarction, anything. And we have done a serial troponin in that patient. It came down to 111. Initial troponins were normal, and serially there is an elevation of troponin. So suspecting ischemia and sepsis, and we also have to do serial troponins, because in that case there is no clinical evidence except the chest pain to diagnose whether the patient is having acute coronary syndrome or not. In this, the only troponin level is the one which is going to help the patient, because the patient is in a sepsis, a borderline BP and all. So we won't dare the patient to take into cath lab and diagnose in that scenario especially. And second and the most important scenario is a patient who is having a creatinine of around 2 and having a chest pain, and when you do echocardiogram there is a concentric left ventricular hypertrophy and there is no regional wall motion abnormality, and when you do initial troponin level somewhere it is around 75 like that. So in that scenario also, as a patient is having a kidney injury, you don't dare the patient to take into cath lab unless it is confirmed, the diagnosis, because after the cath the patient might develop acute renal injury further. In that scenario also, the serial assessment of troponins is vital for the diagnosis.
Yes.
What is the delta? What is the delta?
10%. 10%.
10% delta.
Yes.
So one more
And
interesting...
the idea is if the patients, kind of patients you described, one is sepsis, total count 28,000, heart rate 120, 130.
Yeah.
Here 110 could be borderline. 50 if we mark it cut off, in 3 times if you say 140. So 110 can be, it looks elevated, but for this clinical scenario it can be borderline. And serial troponin can give you an answer.
And one more,
Similarly,
one more important thing, sir. Majority of the patients, they come to a hospital with a slide card method. So in my experience, over a period of these 20 years, whenever the high sensitive troponin value is around 200, in that scenario only that card method is going to be positive.
Absolutely.
So
Yes.
when the level, the patient is having acute coronary syndrome, the level is, if it is 100, by doing a high sensitive troponin, it is 100, assume. In those patients, those slide methods are going to be erroneous, negative and erroneous, and never depend on the slide methods. This
Depends
is my
on which generation, which device, which manufacturer you are using, like Abbott's or Quiddles.
No, sir. I used Alexis C411.
Yeah, so
That's
I
a
think
high-end
Quiddle
machine.
has a lot of, it
Yeah,
can
yeah.
detect up to 2.5 to 5.
Yeah. Mine
nanometer.
detects it is up to 4.
Yeah.
And one more thing, sir. After the thrombolysis or after the revascularization, surprisingly, if there is a successful thrombolysis or revascularization, suddenly the troponin level goes beyond 10,000. That's also an interesting feature. In that scenario, it is very difficult to assure the patient, sir, initial value was only around 2,000 and it has gone up to 10,000. Why this sudden increase? Is the patient deteriorating? The value is increasing. Those kind of things are there. But once the value is more than 10,000, especially my experience is with the troponin T, once it is more than 10,000, we can assure the patient, even with the thrombolysis also, there is a successful thrombolysis.
Absolutely.
Dr. Dilip, your last slide.
Yes.
Dr.
Raghu. That's a well observed finding, sir. Whenever there's sudden peaking of cardiac enzymes, it shows a good recanalized vessel actually, especially this correlating with clinical improvement.
Yeah.
It's really, people think it's, they're surprised with that, but if there's chest pain resolution and other markers, definitely it's a sign of...
You have to see the other markers also, whether ST has down, settled or not,
like,
chest pain has settled or not, and
it's come back, the enzymes are being shown up in the blood because now it's opened up, or something, but it just basically means it's an opened up vessel.
Yeah.
Just as a follow-up to that point, Dr. Raghu, this is Dr. Sai Krishna from Yashoda. So this patient that you had recently, who was centered on the left main, and then he had a drop, which was borderline high, we did not do it. And then on the day of surgery, we just repeated a troponin, it went up to 40,000. The patient's absolutely stable, no chest pain, no ECG changes. So that's kind of, paradoxical that the troponins are going up, the patient is clinically improving. So the other point in which sir had mentioned that when there's a 10 mm ST elevation, I think fair enough to do a troponin because it gives you a relative idea of the myocardial jeopardy that is there, and then you have a baseline against which you're working. So I think it's justified to send a trop in all acute MIs, but this guy had almost a 2,000 elevation of his trop. But it's absolutely sitting stable, no chest pain, no ECG.
It's a sign of opening up the vessel. You can see in the Smith's talk that there is a terminal negative T wave, indicates it is a reperfused LAD. Similarly, an early rise of troponin is a sign of a good thing, not a bad thing.
Somebody with unstable angina, trop is going up, but symptoms are relieved.
See, you see, when it comes to post-procedural troponins and enzymes, there was a controversy on Excel trial. The Excel trial entire result was, there was a debate by Dr. Haggard and Dr. Stones, Greg Stone, about this post-procedural troponin release and myocardial infarction. So it took the results away from cardiologists to cardiac surgeons, and it was then the definition of MI was revised. That was SCI definition was brought in, and then the finding was in favor of cardiologist. So these post-procedural troponins are a kind of highly misleading thing, and sometimes we have to look at with clinical scenario and other aspects as well.
This guy did not have a procedure; he was waiting for one.
Okay.
He was stented already.
Yeah.
And then he came with unstable angina. The drop on day one was elevated, so we were taking him for surgery. Then just to see whether it was trending down or not, we repeated it. It went up to 40,000. patient is absolutely stable.
Yeah.
Thank you, sir. Now, can we have Raghu sir facilitate Dilip sir for... thank you, sir.
Dilip came all the way from Kolkata. Thank you. It's a very busy cardiologist. Yeah, even during election time.